Hi, I thought I would just do a video response to your email just because there's a lot that I want to clarify, and by the time I type it all down I will have done 12,000 dissertations just replying to that email. So I think it'd be best if I introduce myself and sort of explain my service, clarify some of the questions on the email, and talk about the research proposal, so then you kind of have an idea of me, what I'm looking at, what my service can facilitate in terms of a project, and then that might better inform our meeting, because I know we won't be able to meet up for a little while now. So hello, I am Skye. I am a falls prevention physiotherapist. I work for North Tyneside Falls Prevention Service, and I don't work for the hospital falls service. That's slightly different. I work for prevention, so it's a one-stop shop. Patients come, they see a healthcare assistant, and they see me. They can get referred in through GP, urgent treatment centre, ambulance service, fire service. Lots of different clinicians can refer in, but they also can self-refer. That's through a questionnaire that comes through on their phone, or they can do it over the phone. And it basically asks dizziness, falls, all of that. So that's how they get into our service. So the tests that we do, which might help, because I think there's a query on including a frailty score. If I tell you the tests, you can kind of think if you want to include any of that. So the ones that we include is they see a healthcare assistant, that they fill out some questionnaires before they see a clinician. They do a geriatric depression scale. This is a 15-point scale. They do a falls efficacy scale, the reduced version. I think there's 14 or 16 questions on that. We do a quality of life questionnaire, and I think that's all they fill out before they see. That's all I look at anyway. And then they see the healthcare. They get their height, weight, lifestyle, blood pressure, a simple vision test. They have an ECG. I feel that's about it, is it? Oh, and a timed up and go with the clinician, with the healthcare. Okay, then they see me, and I do a 4-point balance test, a 3-meter walk test, their strength, their JMR grip strength, their leg strength, and I do the FRAX screen. Then do whatever else they want. If they get dizzy or anything like that, I do vertigo testing. So that's the main tests that we do. If they then need a doctor, I book them back in, or if there's a doctor in clinic, they go straight ahead. That's mainly for your syncopes or unexplained blackouts or medical falls. So yeah, that's kind of like how the service kind of runs. And I want to talk about the quality improvement project, because there was a little bit, it broke up quite a bit when we had the meeting, so I'll just clarify that now. So I'm looking back at my laptop because I've made notes, so if I'm looking this way, I'm just reading what I've put. So I looked at 3 months worth of patients. That was 140 in total. I looked at, out of those, I looked at 103, because those were the ones that were over the age of 70, because we were following older guidance, which was saying that when you FRAX, you should just be looking at people over 70, which is not the way we do it now, because basically any female that's gone through the menopause, and all the patients we see are over the age of 60. So yeah, unless you're a medical miracle, they'll all have gone through the menopause. So when I did this quality improvement project, it was on a different guidance. So out of those 140, I only looked at 103 because they were over the age of 70. And the exclusion criteria when I was doing that improvement project was those who already had a diagnosis of osteopenia, osteoporosis, if the patient was already on bone protection medication, or if they'd had a telephone consultation, so we haven't got a height or weight. So those 3 exclusion criteria, I wasn't expecting any of us clinicians to FRAX, because they've already got a diagnosis, they're already on bone protection, or we haven't got the information in order to carry out the FRAX. So out of those 103. 79 out of those 103, so many were excluded, so it left me with 79. So 79 were eligible for a FRAX. When I looked at how many had actually been FRAXed, it was only 54. So in percentages, it was only 68.3% of eligible patients were screened. Then out of those 54, 29 were identified that they needed a DEXA scan through using the FRAX tool. Then when I looked at how many had actually been referred, which was using System 1, only 7 had been referred out of 29. So that's less than 25%, 24.14%, which is ridiculous. So I looked at why this was happening, mainly why they weren't being screened, and that was clinicians not having enough time, not having enough information, or not knowing how to accurately calculate the FRAX score. Why the referrals weren't being made is because we used to task the GP to refer for DEXA scan referrals, because politics, you come across a lot of the politics in the NHS. Our service is funded as a one-stop shop. We can't do any follow-up. So when you then refer for a DEXA scan, you have this problem with who is looking at that result. We don't have the time, resources, staff to then look at a DEXA scan result and advice and then action that, because we don't have the same permission that the hospital do to change people's prescription. We can advise the GP, we can advise the patient, but we can't actually change any of that. So the reason why it was being referred back to when we were telling the GP to refer for a DEXA scan is because of all of that politics. So the GPs were then not referring, and when I say GPs, I mean literal GP practices, not just doctors. So all of the GPs in North Tyneside, they weren't then referring for the bone density scans that we were recommended through various reasons. Didn't have time, didn't get the information through, their own administrative issues. I was looking at my service, whatever they did, that's their, whatever they want to do. The changes have been made internally. So we changed it so that we referred internally, but the results went back to the GP. And we had this kind of agreement with the GP practices that, okay, if you're not referring for the scans, we will refer for the scans, but all of the follow-up is going to you, which they've agreed to. So I am the clinician that refers for all the bone density scans. This works in a way that I created a FRAX handy sheet, if you will, where the doctors or me, I'm the only physio, so that's why I say just me or the doctors, they FRAX score, they look at the sheet that I've given, they handwrite, because I don't know how to say this without being rude, they're a bit older, so they prefer handwriting than actually the IT systems. So they handwrite what information I need, apart from the ticky boxes, and make it as simple as possible. And once they've completed that, the sheet gets uploaded onto our system, which we use System 1. They then go onto a wait list virtually on System 1, and then each week I go through the wait list of who needs a DEXA scan, and I refer it on System 1 using ICE. Now, you asked, I think it was, how do you know if they've had a scan? So theoretically I don't, but if everyone is FRAX screened and then added onto the IT system, everyone that I come across I have referred for, because on ICE you can refer and then there's a little confirmation at the bottom that the referral has been made. After that, don't know what happens. They will get contacted by rheumatology, the department responsible for the bone density. They will send the patient out a pack of information, generally ask them some questions, and then I think they basically do their own screening process. and then if they still think they're eligible for a bone density scan, then they do it then, and then the follow-up goes to the GP. So I don't know if they get a scan or what advice they're given after I've referred, because what we've done is seen they need the referral, made the referral. That's kind of where our full service kind of stops, because nobody gets follow-up. That's us done at that point. The problem with us then trying to access that data is we use System 1 and EMIS. I'll try and explain this because I don't know if you know the systems that I use, especially because I know you're Sunderland and Teesside. You might not know this side of the waters process. So half the North Tyneside GPs use System 1, the other half use EMIS. If the patient is on System 1, I can access most of their details unless they've put a consent block on. If they put the consent block on, there's nothing I can do about it. They have to go back to their GP and say that they want to lift the consent, but there's no point because in our service I see them once. So there's no point them doing that because I'm never going to see them again. So I just go off of what they tell me. Apart from, I could potentially ask them to do that if I then want to look at their follow-up or things like that. If they're EMIS, I don't know, I don't have any of their past medical history unless they have been referred by a GP and the GP has kindly give me a little summary, which is nice. The other problem is when they leave our service, we no longer have the rights to access their past medical history, because the reason that we are accessing their history is because they want a appointment with us and an assessment by us. Once that assessment has been completed, we no longer have any jurisdiction in looking into that patient record. So I don't look because it's kind of a grey area with consent to records and record keeping. But if it was for research, I could potentially go in there because I've done it for research previously. It would just be making the patients aware of that. And if I could, so the reason I've gone in previously is to look back at data and not look at what happened next. So I've gone in previously to double check someone's assessment or use it for audit purposes. I have not then gone on it to see what's happened next, because usually I will contact the patient myself or the GP gets in contact and gives me the information I need. So that might be a bit of a sticking point. The other way that I can see around that is if the bone density clinic, you can request that the results go to another clinician, but I would have to be very clear that it's for research purposes so that no patient gets slipped through the net, because if there's confusion and the result goes to me and it's not actioned, then that's an issue with patient safety and it's going to be a breach of all sorts. So there's kind of that. Yeah, so I've kind of talked a bit about what were the changes made. Oh, and just to sort of summary that quality improvement project, there were limitations. This video is going to be way too long if I go into them. I'm just going to attach the Word document so you can have a look. So the limitations within my service that would affect if I do an actual project, like an actual research project and not a systematic review. So we see NHS patients, but we are, because we're primary care kind of, we are employed by an external company called Tyne Health. Recently, the CEO has changed and there has been a lot of staff leaving and staff change. And when that has happened, there has been managerial changes that mean that there's less money and focus on services that were once of interest. I think you can kind of see that and kind of put it in a kind way that at the moment the full service isn't a priority, and it's kind of being pushed to the side at the moment. The reason I mention this is because it's affecting how we run everything. We originally had 5 doctors, now we've only got 2. One of them is going off to get his knee replaced, and the other one is so close to handing the notice in. We used to have 2 physios, now it's just me, and we've recently lost our managerial overseer of our service, and I don't know who's replacing them. Yeah, so it's very limited on time, so fractures are not the priority in our service, and I'm trying to find a way to make that easier, but I have worries that because falls is pushed to the wayside, that actually at some point the service might actually liquidify, which is a shame because preventative services are the first things to go when money's an issue. It's not happened yet, but you can feel the change, and you can feel this might actually stop being a service soon in the air. If that's the case, I don't want to recruit go through ethics, recruit half my patients, and then I can't recruit anymore because the service is liquidified, and then I can't do any follow-up because I don't have access to the patient record, and where am I going to do the interviews or speak to them or gather the data? I would then have to pay for premises. This is all things that would be fine if I was doing a PhD. I'm doing a master's that I can't, the dissertation is not even a meaty dissertation. It's a 2,000 proposal, and then your dissertation and your justification. So I worry about doing a project within the service that requires the follow-up aspect, that needs the data. But we'll put that on the back burner at the minute. I'm going to go to the ideas of the project now. So yeah, we talked about a few different ones. Originally I did go to Dawn and say that I was going to compare fragility fracture tools, but you're right, they are well researched, saturated market. We all know the right thing to do. Everyone should be screening for fragility fractures. When I speak within my service and then our doctors and our GPs, and I ask, are they doing it? Because the doctors, they do a half day in our service, the full service, and then they do their main jobs. So some of them work in the hospitals. I say some of them, there's 2 now. One of them's a GP, one of them is a geriatrician. So I ask what happens in the GP sector, and if they frax and they say, no, haven't got enough time, 8-minute appointments, we can't be doing it. When I ask in hospital, it's more of a, you've broken your bone, okay, we'll frax. Whereas it should be used as a tool first off. So the systematic review of looking at should we be doing it is all saying yes, and which tool you use, it should be either Q fracture or frax, and yeah, there's systematic reviews discussing both. So I don't think that is an area that I can really pull at, because there's evidence to say you should be using Q fracture or frax, and we should all be using it. The problem is doing that in practice, and that's the thing that I want to change, and that's where the confusion with the project title and the project question comes in, because I want us to all be using a preventative tool and to screen osteoporosis and penia and then give the patients the advice, but I want to know how we're going to do that. So I could look at the barriers using frax because I can kind of use the quality improvement project that I used last time and talk about time constraints, but then when you look at previous quality improvement projects, any quality improvement project, the main things that tend to come up, especially with the NHS, is time, staffing and money. If we know that, we can't fix that. I know that we've recently changed political party and hopefully that the funding gets better, but realistically, for the foreseeable, I'm not going to be able to get more staff, more money or more time. So even if I know all of that, I need to find a way around it so that we can do it with the staff, with the time and with the money that we already have. Which, when I was speaking to Dawn, there was like this throwaway kind of idea that actually stuck with me a bit, is trying to create a way for patients to screen themselves. Is there a way for patients to put the information in, or kind of get an idea or fill out the information for us, and then it calculates that FRAX score, so it takes out the need for the clinician to do it? That's a huge project, and if that was to go national, it would need to use IT systems, and it would need to look at reducing patient error and making sure that they fill in the details correctly and it doesn't give a false reading. But that's what I'm now looking at within my service, regardless of university, is there a way that I can do a questionnaire, just like how they complete a GDS and FES quality of life questionnaire, where they put in some information and then either a clinician either puts it all in, because someone's got to put it in. It would be who has the authority to put it in. When I say put it in, I mean the IT systems, because we can't run without IT systems. Does a clinician have to put all of that information in because it's data collection? It's not data analysis or extraction, it's collection. So would it save time if an administrative person was able to gather that information and use the tool? The only problem is there is errors and maybe needing more of a clinician's knowledge to know. So, for example, one of the questions is, do you have rheumatoid arthritis? Some patients might tick yes, thinking that it's osteoarthritis. Happens a lot when I ask if you have it. And then an administrative staff might not necessarily think, oh, or even have access to their medical history to then correct that. So maybe not. I'm kind of thinking out loud as I'm doing this video as well, as you can tell. So yeah, I'm kind of looking at ways around. The bottom line is, we should be using FRAX or QFRAX or whatever. We should all be using it. We're not. How do we get us to use it? Because even though I'm all for it, when I'm slammed and patient after patient after patient and I'm 30 minutes behind, FRAX is not on my agenda. Absolutely not. And that's someone who's interested in this area and wants to change the world with it. So there needs to be a quicker way of doing it. And then just to add, I think on one of the questions it said adding in a frailty score. We do use a Rockwood frailty score already. That's usually part of the doctor assessment that they calculate it. But if you want to involve it, I can just add it onto my assessment that I already do. I'm just going to go through your email to see if there's anything that I've kind of missed. The only thing is availability, I think. So my availability remains the same and will always be the same. I can do anytime Mondays. I can come over to Sunderland, not a problem, although I don't have a car at the minute. broke down on Monday, clutch went, nightmare, had to coast it home. Hazards on 4 or 5 times because we won't go. But hopefully I'll have one in the next week or 2. But Sunderland I can get to anytime Monday. I can't get over there any other time of the weekday unless it's after 6:30, because I work 8:30 till 5:30, and then it's getting changed because I wear scrubs and things and getting across and parking and all of that, going through the tunnel. Potentially on Friday afternoons, I could possibly do 4 p.m. And then on weekends, with plenty notice, I could kind of negotiate weekends, but my availability remains the same. I'm the only physiotherapist in my service. Mondays are my day off and study day. There's no negotiation on it, absolutely none, because I'm in clinic when there's a healthcare in the clinic, because they come and see healthcare and then me. There's no healthcares on Monday either, so I can't even switch a day to compensate, unfortunately. So let me know how that will work. Oh, Wednesday mornings I work remotely, or I have to go in for meetings. It depends. When I say I work remotely, I still have telephone appointments with patients. I still have to do work. It's just that I'm free for a Teams meeting on a Wednesday morning or a local meeting, because if I'm only gone an hour or 2, I just add it onto the end of my Wednesday clinic. So instead of finishing at 5:30, I finish at 6:30 or 7. That's how I can be available on a Wednesday morning. But yeah, I can't get to Sunderland and back and have a meeting during that Wednesday morning. It just can't be done. So Mondays all day, weekdays after 6:30, or over a weekend. So yeah, you can see now why I did a video, because if I was to sit and write all of that, yeah, ridiculous. I'm away now. I'm on holiday officially. Woohoo! I'm going to Cornwall with my dad. So excited. I am taking my pad, so I can still have a look at emails and things, but I'm on holiday, so not a lot of chance of me doing much studying or work. I desperately need a break. But we will catch up, and any questions from what I've said, then let me know. But I just thought it would be easier for me to give an introduction, give some background on some of the questions that missed on the meeting or there was a bit of confusion with, and then it gives a bit more food for thought for where we go from here. Because at the minute, I absolutely appreciate that you're here to help me and Dawn's here to help me, and it's really, really great to have someone with that same mindset. But at the moment, I'm kind of getting stuck in how or what am I doing, and kind of desperately thinking, do I just absolutely throw this in the bin, this idea in the bin? So if you could help me not throw this idea in the bin, because I'm very close to just choosing a different project idea altogether. Yeah, but I want the change. It's just how to do it in a failing NHS with limited time and clinicians that are leaving the service left, right and centre can be a little bit difficult. Also, before I go, if you're ever thinking about using the bone, the DEXA scan at Sunderland, I would be up for that. However, getting the patients over to the other side of the water, not going to work. I can't even get people from Wide Open to Wallsend. It's a 20-minute drive. There's no way they're going through the tunnel. I can't. Our exercise classes operate out of North Shields. Anyone from not around the coast, they don't go. They would rather just not. So getting them through a tunnel, paying for the tunnel, and if they don't drive, get into Sunderland. Then I get into the finicky of paying for transport. That's PhD. That's not masters. So in case that was in the background there, I would be all for it. But yeah, I don't think they would come across, and even some of them don't even want to go to North Tyneside Hospital when they live in North Tyneside. They want to go to the Freeman or RVI, so they're very picky. But we can discuss that if we get any further forward. Okay, I will speak to you after holiday. Bye.